Hi guys, my name is Erin and today I'm just going to be teaching a little bit about antipsychotics, mainly first generation and second generation antipsychotics. So I'm going to start with first generation and give a little description about them. We usually give first generation for schizophrenia, bipolar, and other psychotic disorders, and their mechanism of action is that they are dopamine antagonists. An antagonist is something that works against or blocks, and an agonist is something that works for or towards. So when we give these drugs, they block the dopamine from being reuptaken into the system. And one thing we have to think about when giving these drugs is they have a high rate of extrapyramidal side effects, and those include muscle rigidity, bradykinesia, dystonias, tremors, tardive dyskinesia, and then also neuroleptic malignant syndrome, which is highly fatal. So when we give these drugs, we want to monitor our patient for any of these side effects. So I have a mnemonic or a little saying that I came up with to remember first generation antipsychotics. My first one is how low? Chlorpro. Funny pun. Doesn't really run smoothly, but it's something that I came up with to help remember these drugs. So how low, I started with the H and the L for these two drugs. Chlorpro is for chlorpromazine. Funny pun is again using the beginning of fluphenazine, and pun is for the beginning of pervenazine. So the drugs for first generation are haloperidol, loxapine, chlorpromazine, fluphenazine, and pervenazine. So there's another way to remember these, and it's also the ends of the drugs or the suffixes. And so there's dol, pene, zine, zine, zine. So that's also a way to remember them. With the first saying that I came up with, haloperidol is highly potent, and so you're asking how low? Chlorpro, and chlorpro is actually, it has the least potency out of first generation antipsychotics. So that's kind of why I put that in there, but I'll give a little description about each of the drugs. So starting off with haloperidol, again, it is highly potent. So when we give this drug, we want to watch for those side effects that I mentioned earlier, like the extrapyramidal symptoms. And then loxapine, the next drug, the mechanism of action isn't really known as well, besides that it's a dopamine antagonist. And when we give this drug, the inhaled dosage form is given for the acute treatment of agitation, usually associated with schizophrenia or bipolar 1 in adults. And usually patients prefer the inhalation dose over the pill. Then we come to chlorpromazine, and this is actually the first conventional antipsychotic developed, and it's still widely used for the treatment of schizophrenia. So, and then it's also a low potency drug, so that's why we like to use it as well, because we don't have such a high risk for those side effects. Fluphenazine is highly potent, so it's actually pretty similar to haloperidol, so we want to watch out for those side effects. It also has the anticholinergic effects, so if you remember that, that's no C, no pee, no stool, and no drool, so basically it dries up all the secretions in the body. And then pervenazine, it has a slightly lower potency than haloperidol, so it's not such a high risk for the side effects that I mentioned in the beginning, but it still has the possibility, so we want to watch that when we give patients. And then moving on to second generation antipsychotics, a description about those drugs is we also give them for schizophrenia as well, and mania, bipolar, and dementia in the elderly as well. And the difference between first generation and second generation is that first generation are dopamine antagonists, and second generation are dopamine and serotonin antagonists. So they block both. And they have fewer side effects, so they're more efficient. And actually, second generation antipsychotics are usually the first choice of drugs for mental disorders. And they have a lower risk of the extrapyramidal side effects, but they do have other side effects such as weight gain, diabetes mellitus, sedation, and orthostatic hypotension, so we have to watch for those as well. And then something that I found out in my clinical experience is the cost of these drugs to patients when we're looking through, what things we're going to be billing the patient for. Second generation drugs are actually pretty costly compared to first generation. So if we were to give clozapine, which is a second generation drug, it's around $4,000 a year to give that drug to a patient. But for haloperidol, which is first generation, it's about $50 a year. So there's quite a difference in cost, which can be really difficult for the patient to determine whether they take that medication or whether they spend the money on a different medication. So my little saying that I came up with was, "'Cause quit all risks." And that's because, like I mentioned before, second generation drugs have less risks with the side effects than first generation. And I just took the C, the O, and the Z to spell "'cause." Quit starts with the Q, all starts with the A, risk starts with the R. So that's how I came up with all of this. And the drugs for second generation are clozapine, olanzapine, zipridone, quentapine, sorry, I'm butchering that one, asenapine, and risperidone. And I'll give a little description about each of those. So clozapine, you're going to see this a lot in your clinical rotations, especially in mental health. It's the first drug of second generation antipsychotics. It's mostly effective, so we'll see this a lot. But there is a risk of agranulosis, which means that white blood cell count will decrease, and that will lead to your patient being immunocompromised. So we have white blood cell count monitoring every week for the first 6 months of treatment when you give this drug. It's highly important that you follow through with that and that you monitor it in your patient, because we don't want them to catch any other infection because their immune system is down. Other adverse effects include sedation and the drooling, constipation, and cardiac effects. So we want to watch for that as well. And then olanzapine. Common side effects of olanzapine include weight gain and sedation and hypotension and constipation. Then there's zipridone. It treats acute agitation in patients with schizophrenia, and it appears to cause less weight gain than the other drugs in the second generation category. So for patients who are not comfortable with that side effect of gaining weight, you can give them this drug and they'll have less of a chance of gaining as much weight than with the other drugs. Quetiapine, so again, adverse effects include the sedation, the weight gain, and the orthostatic hypotension. Asenapine, so this is interesting because I didn't know this until I took Stephanie's class, but she taught us more about it, and it's actually absorbed poorly in the GI tract, and so they give this drug in sublingual form. So underneath the tongue, you place it underneath there, wait for it to melt, it's absorbed. And so I did not know that, but that's important to remember. And common side effects also are, again, the weight gain, sedation, orthostatic hypotension, just remembering that. And then risperidone, again, is the hypotension, sedation, and then there could be an increase in prolactin. It's a hormone, and that increase in prolactin can cause breast tissue increase. So if you're giving this to a male patient and they feel like their breast tissue is increasing or tender or swollen, just check for that because that could be a side effect of this drug. And that's all I have for first and second generation. Hopefully you guys found this helpful. Thank you for listening.